kalau harga minta tu, ini macam ni mungkin ada few lah kalau yang boleh foto dan buat dia boleh minta tu online. Saya okey, dia ada kat ni, tapi dia pun boleh check, kan? Dia ada buat.
Try buat. Tapi okey senang tu.
Sebab yang spesialis tu baru je, dia baru sambil kan, so okey lah, dia boleh cancel, dia mesti digabung. Ya lah kan, kita macam hari ni
Tahu dah bangsa obat.
tapi ramai dah macam cakap kat ni lah, problemnya dia macam jadi sekali kita boleh tengok kita boleh plan kita punya ni kan dia buat ini macam aktiviti orang pun so kita tinggal buat plan tapi kita boleh buat maknanya kita boleh bagi online kita boleh bagi
semua benda yang konten dalam link tu bila kita pilih macam independent
saya rasa macam ni kita masukkan dalam hospital website link untuk view booking tapi booking tu tak boleh di-edit hanya boleh contact PIC saja
bila dibuka kan dia ada chart, dia ada form, dia ada Google ni so kita nak yang mana yang yang pasal kalau berdasarkan start yang sudah
menu aja sebabnya
bila kita share mudah kita
ini tengok menu aja sebabnya
ada hadiah ada hadiah
So yang tu nanti nak bagi mic ke sebelum jawab tu tak ada sejadah dia. Saya mana pilih je lah. Saya tak ada siapa yang bagi
Mira, bilik department penjaga dia punya grup dah dia kan?
Buat Lisa ada meeting kemarin ni pun dia tak
Tak diinform dia tak? Ya, kalau dia cuti dia tak apa. WhatsApp bukan tak tadi dia
pesan je.
dia ajak lah.
Tapi
Saya tak ambil nanti dalam dah tahu dah nak baca tak? Ada yang cilik.
dia terganggu. Sebab saya mesti dapat.
Tak bayar. Nanti dia, saya bagi dekat Amir.
Video tu saya tahu
Sebab ada yang acik
cuba cakap
jadi
I tulis nama I bawah ni sebab I kata ni, I kata
ini kat mana nak next? Oh ni bukan ni kan? Oh. Slide next tak ni lagi.
Jadi next slide.
Oh enter.
Oh.
Okay. Oh dia tak jadi slideshow untuk presenter lah kan? Ha. Tak apalah. Ada lagi tak?
Amir ada.
Ni dapat dah ke flow dia ke? Ya pada flow dia ke?
Ikut dalam tu.
Ha. Tak. Ada dah kita control tapi ikutlah.
Lagi tengok.
Oh ya. Zaman-zaman dulu betul. Betul lah. Zaman dulu. Betul Ahad. Tapi memang betul Ahad memang jadi
Masih kan? Poesi kan ada cerita. Ada announcement, ada yang asli nak inform dia sikit. Apa ni? Dengan sekali dengan macam itu itu cuma ada dia kali naik Dah.
Kau buat ni sini. Dia kata ada si kata dia ada si dia ya.
Tengok.
Mana nak tengok? Tak ada dia video file lain. Video nak tengok sini nak tengok pasal sini bukan video dalam slide. Video asing. Video launching lain. Atas ni. Betul tu. Q dekat ni turun tu. Boleh jadi lah kot untuk ni. Ni ada Q.
Ladies and gentlemen, we are about to begin shortly. Please be seated and ensure your mobile phones are switched into silent mode. For attendance, kindly scan the QR code displayed on the screen or use the attendance link via WhatsApp application that has been distributed to a person in charge in the respective department. For participants from district hospitals who join the CME via online, any questions are welcome through the chat box in YouTube channel. Assalamualaikum, mohon penuhkan ruangan rapat. Kita akan bermula sebentar lagi. Assalamualaikum and a very good morning to our honorable guest, Dr. Tengku Anas Fati bin Tengku Ahmad, Deputy Hospital Director 2, Head of Departments, Specialists, Medical Officers, Nurses, and the rest of HRPZ staffs. First and foremost, I would like to thank everyone for allocating your time attending our CME session today. I am Dr. Amanina from ONG Department, will be your MC for today. Without further ado, I would like to invite Sheikh Hanan Hayati Marat, our pharmacist, to present today's CME with topic Antimicrobial Stewardship Update. What's up, guys? Please welcome.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good morning to Dr. Tengku Anas, Deputy Director Medical 2, all HODs, consultants and specialists and all my fellow colleagues. So my name is Hanan Hayati, pharmacist from a pharmacy department. And before I proceed any further, I would like to ask a permission for everyone for me to deliver my topics today. To me it's in Bahasa and maybe some in Kelantan. Okay. So kalau tengok tajuk ni macam ala-ala kerami sikit kan, pasal guys. Tapi I will not share marvelous delicious recipes from kerami. Iklan. Okay, but then I will share a few recipes so that we can use our antibiotic judiciously and appropriately. So this is the content of my presentation for today. Okay, so to begin with, I would like to introduce about AMR, which is antimicrobial resistant. So AMR, I think everyone know dia adalah, kalau kita selalu tanya, apa itu kerintangan antibiotik? Apa itu kerintangan antibiotik kan? Okay, so AMR, however, it's actually a global health threat and it is found that about 5 kematian yang menyebabkan kematian 5 juta setahun, dan with the limitation of advancement in technology of antibiotics and lots of infections. So this has concluded that AMR termasuk dalam top 10 yang menyebabkan kematian. So it found that people are more likely death due to AMR rather than cancer lah. Okay, so antibiotic dan resistant ni, antibiotic resistant ni dia macam bayang-bayang. So whenever we start antibiotic, there's a resistant that will follow the antibiotic. So kita boleh tengok contohnya 3 cycling, dia antibiotik yang barulah dari golongan tetracycline. So dia baru je diperkenalkan kepada kita 3 cycling, but then a few years lepas tu je there's a resistant that been reported. Okay, so there's lots of factors that contributed to the antimicrobial resistance. For example, for the drug itself, so kita bagi the high-end antibiotic lah. So bila dah bagi high-end antibiotic, kita bagi pula dengan antibiotic with the inappropriate regimen. So kita bagi yang low dose, kita bagi lama. Then what about environmental? Environmental, tak basuh tangan. Okay, patient yang ada MBRO, kita tak cohort. Okay, then the inappropriate use of antibiotic dalam animal. So kita tak perlu masuk ward pun nak dapat colistin. Makan ayam pun boleh dapat colistin. Okay. So patient also contribute to the AMR. Kita kalau dekat farmasi kan, dekat kaunter, kita kerja, lepas tu patient datang, tak ada antibiotik, Panado je. Kita pun, alamak, explain lah, panjang explain ke patient kan. Sebab dia fikir bila demam je, antibiotik. Dia demam je, antibiotik. And then, bila bagi tak habis pula okay. Sebab kita sendiri pun siapa pernah ambil Augmentin, tablet Augmentin. So tablet dia quite big and then TDS. So kita me myself pun quite struggle jugalah nak habiskan antibiotik cause dengan aku siap. Okay, and the last one is prescriber. So it's found that about 50% of antibiotic being prescribed inappropriately lah, whether it is being given where it's not needed, when the diagnosis is wrong, dan juga dengan inappropriate regimen lah. Okay, so kita berkenalan sikit dengan musuh kita. So antibiotic or antimicrobial is rather different compared with antihypertensive or antibiotic agent, sebab kita bagi antibiotik untuk fight dengan bakteria. So bakteria macam juga manusia, dia nak survive. So bila resistance happen, so dia actually for the MBRO adalah bakteria yang resistant to one or more classes lah. And then the classification actually been classified to the extent bagaimana perbezaan dia resistant kepada different classes of antibiotic. So I listed dia all the example macam banyak kan. So kalau kadang-kadang patient bila dapat culture yang ada growth in organism resistant macam ni, dan kita dengar je lah semua resistant, tahu nak bagi ke apa kan. So bagi apa, air infusion. Okay, dan kalau MDR only, it's not only, we found that not only when patient admitted in ward, sometimes for example, patient yang tak pernah ada admission, tiba-tiba datang culture, ambil blood culture, ambil pus culture, urine culture from ED, kita tengok ESBL. So ESBL not only found in the nosocomial dalam hospital acquired infection, but then dia dah berada di community. Okay, so I share distribution of healthcare associated MBRO 2022 ini kita punya AMS lah. Okay, so about 77% adalah gram negative MBRO. Predominantly Acinetobacter, which is contributed to 27% lah. Okay, so kita tengok MRSA rate. Okay, alhamdulillah, okay, macam reducing trend kan. Okay, daripada 2022 kepada 2022. Okay, Okay, so what about dekat hospital? So I zoom into kita punya HRPZ dan juga kita punya jiran lah. So MRSA rate, HRPZ still below national average, tapi USM dah exceed lebih sikit daripada national average. So dah masuk USM. Senyap Okay. Okay, walaupun tadi I share the MRSA rate decreasing, but then MRSA bacteria mortality actually climbing up. So walaupun MRSA infection to decrease, tapi dia punya mortality still increasing lah. So kita still kena take note mengenai MRSA ni. Okay, what about estimated bowel money? Okay, so HRPZ, USM, okay, dua-dua tidak berjaya, berada di bawah national average. Okay. Okay, so this is just the trend of the MDRO for all the MDRO yang kita monitor dekat AMS lah. Okay, so what can we do about it? So first, kita try to prevent the infection, and then we made a proper diagnosis and treatment. So yang ni I leave ke semua doktor kita yang hebat-hebat lah. So and then for the antimicrobial resistant, so kita try to optimize the antimicrobial use. Okay, so there's come the AMS. Ada orang tak pernah dengar lagi tak AMS sebenarnya? Okay, so AMS adalah Antimicrobial Stewardship Program. So walaupun ada perkataan steward kat situ, so kami bukannya stewardess lah ataupun steward. But then stewardship sebenarnya adalah dia kita helping, kita nak make sure that kalau naik flight tu kita nak make sure journey selamat, selesa dan kita sampai ke destinasi. Okay, so AMS like no action today, so no cure tomorrow. So this just like more to definition of AMS lah. So kita nak promote appropriate use dengan kita make sure optimize dia punya treatment dan juga kita nak minimizekan dia punya ADR and minimizing harm kepada patient lah, which is not one of them is the resistant. Okay, so AMS ni macam PZ. Okay, kalau AMS antibiotik mesti fikir ID saja, ID. Sebab farmasi supply ubat, farmasi. So AMS is not only the ID dan juga farmasi lah. So we actually have come up with the memos, surat lantikan which is dipengerusikan oleh hospital director kita, and then ID consultant especially sebagai coordinator lah. So and then we also have a specialist which is the representative for department. So for example, kita ada Dr. Nazri from AMS, Dr. Nick from pediatrics, and also we also work together with microbiology, so they provide a good culture to us, and with the staff nurse for the infection control, so they advise on the cohort and a good cohort lah. And then last one is pharmacist. Okay, AMS sebenarnya kita dah start AMS actually in 2013. So kita sebenarnya dah 10 tahun. 10 tahun dah jawab apa Okay, so 10 years is about sedekad. So I would like also to take this opportunity to thank the managing team, Dr. Anas, and sebab they all give, bagi support dan juga tremendous effort bila kita nak buat any program tu, dia okay boleh okay buat macam. So they are very helpful whenever we come up with our program, with our intervention in order to make sure that our AMS berjalan dengan baiknya. Okay, so initially in 2013, 2014, so we more into initializing and awakening of AMS lah. So we establish our AMS team again, we provide with the surat lantikan, and then we start with our AMS round. Initially we are only round for carbapenem lah. So kalau tengok tiba-tiba kenapa ada ID ni, kita tak refer patient pun, sebab masa tu kita tengah pergi tengok patient on carbapenem without referral to ID. And then we start quinolone restriction or quinolone holiday. Quinolone ni pergi holiday tak balik-balik, masih lagi bercuti. And then we also started our antibiotic request form, which is AAR form. And then we dah slow start kita punya survey lah. So kita buat surgical point prevalence survey, antibiotic survey. Okay, and then in 2017, so kita dah start buat roadshow to other hospital. So kita nak expand our AMS service to other district hospital. So kita buat roadshow to HOSIP, HTM, HPM and all the district hospital. Then we come up with the antimicrobial injection dilution and stability protocol, the first edition lah. Okay, in 2019 kita slow down sikit AMS 2019 sebabnya COVID. But then we still manage to add round for the MSSA, bacteremia, also vancomycin. So whenever patient grew Staph aureus in blood, so we will review the patient, and also when patient also started with vancomycin. In medical wards, kita start review third generation cephalosporin. And then we unofficially started OPEC dekat MDC. So masa ni patient yang discharge, kita minta dia datang dekat MDC or SDC untuk dapat antibiotik terapi lah. Okay, 2021, the continuity of service. So kita masa ni sibuk dengan vaccination, but then we still manage to start OPEC and clinic waiver officially. Okay, 2023. So kat sini tahun lepas we establish our first antimicrobial policy. So bila kita dah 10 tahun baru kita tak ada polisi pun. So kita tak ada satu macam pegangan lah, kata masalah lah pula kan. So polisi yang kita kena stick ni yang kita punya healthcare workers kena cautious guna antibiotik, kena control anything, apa yang nak kena buat bila start. So kita tak ada polisi. That's why kita publish satu polisi lah last year. And then HRPZ actually has been appointed as the AMS training center for pharmacists for East Coast region lah. Okay. So this is our HRPZ2 antimicrobial policy. So we already download, make it available at HRPZ official webpage. Dan kalau siapa-siapa buka Facebook tu pun boleh dia direct untuk download HRP policy. So kita actually has distributed the hard copy kepada HOD, but then to everyone you can always get the copy, the e-book of our policy. Okay, so siapa yang datang boleh scan this QR code. So it will link to our AMS link tree. So dalam AMS link tree, we are not only provide policy, then later on you will see that there's lots of antibiotic reference that we included in our AMS link tree. Tapi bila saya try buka dekat link ataupun internet hospital, dia tak boleh buka. So I rasa dia block link tree lah. Okay, so I proceed with our next slide. So these are the contents in our policy that comprise of strengthening of AMS principles. So we come up with the antibiotic stop down. We have the antimicrobial formulary and restriction, antibiotic order tools, cover panel review, IV to oral switch, and the last one is OPEC. Okay, so we stated our basic AMS principle where we actually come up with the stop doc. Okay, like macam stop doktor, stop macam gitu. So bila dia nak start antibiotik tu, dia kena fikir dia revise adakah ada infection ke? So kalau tak perlu antibiotik. And then to trace whenever culture, is for oral. Whenever patient are suitable to change to oral, so it's preferable to change to oral, and prescription to review. When patient ada renal problem, so nak increase dose ke, nak tukar dose ke, so that needs to be reviewed regularly, and to de-escalate to narrow spectrum antibiotic whenever possible, and to look for possibility if patient can refer for OPEC. Okay, so if patient kena continue dengan antibiotik, so again to review within 72 hours, kita hope that bila 72 hours culture is already present, and then the last one is shorter is better. So sebelum ni kita selalu macam plan, okay antibiotik ni for 5 days, 7 days. Tapi kalau patient tu contohnya dari auto transfer ke medical, so kita PTO prescription lain. So daripada auto seminggu, masuk medical seminggu. So jadi 2 minggu. Sedangkan daripada auto plan untuk seminggu. So we are advised all prescriber bila dah determine duration of antibiotic to mention the stop date. So we pass over antibiotic therapy. Okay, nak end our antibiotic 10 hari bulan 1 macam gitu. So that adalah kita daripada seminggu auto sambung seminggu medical. So kita dah stick kita punya stop date. Okay, so again antibiotic AMR. Okay, so as I mentioned before, antibiotic causes emergence of antibiotic resistance, especially in high risk antibiotic, because some of antibiotic has a higher propensity to select out resistance. For example, third generation cephalosporin, especially ceftazidime. Okay, so ceftazidime kalau kita guna, kita put patient at risk more to the dapat ESBL lah. Okay, so this just to show the higher risk of antibiotic and all the resistance. Okay, so WHO actually has classified the commonly used antibiotic into 3 groups, which are access, wash and reserve. So access group ni adalah antibiotic with the lower yang akan menyebabkan resistant. So for example, augmentin, more to the beta-lactam and beta-lactam antibiotic. But then I will highlight clindamycin because we might misuse the clindamycin, so patient might get C. diff infection. Okay, so in the MyAPMR, so they also indicate that at least 60% of overall antibiotic consumption comprises from SS group. Okay, so kita nak kalau boleh antibiotik yang kita gunakan patient yang tak very ill, so kita more into the SS group antibiotic lah. Okay, so in our policy kita has classified antibiotic yang available in HRPZ into antimicrobial traffic light categories. So yang accessible tu kita categorizekan into yang hijau, so yang biru, biru pula. So yang kuning that require authorization by specialist, and the last one yang merah ni require pre-authorization from ID lah. So ni example antibiotic based on category. Okay, so quinolone restriction and quinolone order form. So actually why quinolone? Ada tak sesiapa terfikir kenapa ID, kenapa kita restrict sangat quinolones ni? Okay, so why quinolones? Kita ada beratus-ratus antibiotik, so kenapa kita restrict betul-betul quinolone? So Kelantan is well known dengan air tebing ni kan. So bila air tebing ni Kelantan is actually highly endemic for typhoid fever lah. So previously we use lots of quinolones to treat typhoid fever. Then we also find out that there's increasing in resistance to quinolone. It's not only that, bila kita look at our antibiotic utilization, so quinolones, which is levofloxacin, ciprofloxacin, so we found that kita punya HRPZ sebenarnya dia punya usage dah exceed upper limit national. So kita selalu kena bagi justification lah kenapa kita tinggi guna quinolones. And with the use of quinolones, there's related to the MRSA trend. So kita tengok bila banyak guna quinolones, banyaklah MRSA. Okay, so quinolones actually favorable drugs because it's not only it have a IV and oral formulation, and dia punya oral sangatlah good, dia punya bioavailability with the good penetration to the tissue, to the lung. So dengan dianya ada a very good broad spectrum coverage, dia ada cover pseudomonas, so we tend to use quinolones a lot. Dia punya dosing pun OD to BD, so we hope that patient is more compliant with quinolones. But then FDA actually has come up with a warning to us for the serious side effect of quinolones, for example with the IV and high dose, so patient might get arrhythmia, and then the permanent side effects such as tendinitis and then the rupture. Okay, so for this time we discuss untuk quinolones kita nak state approved indication, a few indication yang kita boleh gunakan quinolones. For example, salmonella infection, pseudomonas infection, but then all these indication need to get authorization from ID or ICU in a case of ICU cases lah. Okay, except for these two indication, alternative treatment for mycobacterium tuberculosis. So patient, for example, previously on IFURI or EHZ regimen, but then developed DILI, and then we change to levo. So you don't have to refer to ID if you want to change to levofloxacin. Also for the treatment of NTM. So bila macam ni kita akan guna form lah untuk kita control usage, so kita tahu indication dah referral dah berbeda ID ke belum. But then siapa familiar dengan form ni? Siapa ni ada familiar tak? Okay, so previously we use this antibiotic request form yang biru. So bila kita doktor start antibiotik yang kita control, so tak ada borang, so farmasi bagi borang kosong, hopefully doktor isi lah kan. So bila sampai next, kosong lagi, bagi balik. Yang kedua sampai, ada job doktor saja. Yang ketiga sampai, lunyai dah. So that's why we are not only try to save our precious antibiotic, so we also want to preserve our green mother earth. So that's why, so this time kita dah tak guna dah. So kalau ada terlepas borang ni, mungkin boleh masukkan dekat recycle bin. So we are no longer using this form lah. So we are into an online system. Okay, so quinolone order form. So all injectable or oral quinolones prescription require quinolone order form that to be filled through online. So we come up with the Google link. So prescriber need to fill up these details online saja. Okay, so where to find this link? So kita sebenarnya dah distribute memos to all wards and clinics with the posters to mention untuk letak QR code so that the prescriber can scan and then fill up the form lah. So we also has put the link in our AMS link tree so that everyone can have access to our quinolone form. Okay, so kita dah start actually QOF ni since August last year, and then we try to look at dia punya compliance lah. So kita nak tengok orang guna ke tak. So we did some audit lah, kita tengok. Tak ada survey lah juga sebenarnya. So a total of 171 patient. So where most be prescribed with levofloxacin. However, only 40% receive quinolone order form. So kita still supply sebab kita call doktor, doktor yang ni kena isi tapi tunggu. Tak isi, tunggu tak isi. So patient marah kita sebab lama tunggu. So kita noted dah discuss what is the indication and then we allow for supply lah. So saya harap ada matron, sister try to help us to tengok dekat ward, dekat klinik, sebab klinik saya rasa ada banyak bilik doktor kan. So kalau boleh untuk display kita punya poster tu dekat semua bilik doctors lah. Okay, and then kita pergi tengok satu case lah. Okay, so case scenario 1, 71-year-old visit the SOPD. So problem at BPH with renal stone and underwent open vesicularectomy on 25th of January. Okay, so to cut it short, patient actually planned for TERP on 7 bulan 6. But then was prescribed with dutasteride and tazolocin dan juga tablet ciprofloxacin. So are we going to release this quinolone to this patient? Tak, kita intervene, kita call surgeon, tanya doktor kenapa nak bagi ciprofloxacin. It turn out that untuk surgical prophylaxis. Mesti patient datang bulan 3, nak buat op bulan 6. Antibiotik dah bagi, kan? So patient simpan kat mana antibiotik, tak tahu. So kita ask them to refer to ID. So it's not granted. So kita omit this supply lah. Okay, so case scenario 2, patient visit at ENT clinic. This time patient has swab culture Pseudomonas aeruginosa and then actually have a problem with left malignant otitis externa. Siapa perasan? Indication ni included dalam required ID authorization. So medication prescribed also tablet ciprofloxacin. And then are we going to release these quinolones? Do they have to refer to ID? So seperti yang saya bagi tahu, semua quinolones kena refer ID. So due to the indication indicated, and then this quinolone actually be granted by ID, but then we increase the dose lah. Okay, for the MOE, the recommended dose is 750 mg PD. And then for the managing team to submit online QF to pharmacy. Okay, case scenario 3. Okay, patient 80-year-old Malay admitted in Bendahara with the PTB smear positive, right pleural effusion. So patient initially on accurate form, but then was changed to AHRL regimen due to the drug induced liver injury. So patient was prescribed with levofloxacin 750 mg BD. So are we going to release this quinolone to this patient? Again, do they have to refer to ID? So sebab I mentioned before, this indication no need to get ID pre-authorization, but then the managing team still need to submit the quinolone order form. Okay, bila kita dapat all the details, so we can use all the information yang kita dapat daripada details yang dimasukkan dalam online form. So kita dah ada indication. So kita dah ada siapa prescriber so that we can use that information whenever we need to give the justification to the KKM bila kita become one of the high user for the quinolones. Okay, so next is 72 hours carbapenem review. Okay, so carbapenem can be started by specialist. So sebelum ni tak nak start sebabnya ID. So ID pun pening lah sebabnya patient might be ill, might be shock dekat ED, dekat other ward. So kita tak kita allow carbapenem untuk being used lah. But then AMS team will review the carbapenem for 72 hours. Okay, so we go to the satu case scenario lah. So patient admitted in surgical ward treated as acute pancreatitis, but then on third day of admission, complaint of bloated stomach. Then CECT was done, shows that patient necrotizing pancreatitis. Noted that patient total white cell increasing, CRP high, so they started with IV meropenem lah. Okay, but then at 72 hours, AMS review the patient and noted that blood culture, no growth, total white cell, nampak improving, so they escalate to IV tazocine. Okay, so this is due to one of the guideline that in severe of acute pancreatitis, most pathogens. So we try to give the narrow spectrum antibiotic. So one of the recommended antibiotic is also tazocine. So bila kita review carbapenem, so kita tengok kita make the de-escalation. So if we look at the carbapenem utilization from since 2030, so kita tengok dia punya trend is declining trend lah. So yang biru since 2013, 2015 tu bukannya tak ada data yang selain daripada ICU. Tapi bila 2016 kita baru start keluarkan data all wards, kita asingkan dengan yang ICU lah. Sebab ICU kita lain sikit dia punya antibiotic utilization. Okay, so next is IV to oral conversion. So we know that IV to oral has lots of benefit. It's cost effective, patient boleh minimize IV therapy, thrombophlebitis, and then kita boleh discharge patient awal kan. Okay, so in our policy, we have stated the criteria for IV to oral switch therapy. So prescriber need to look at the clinical condition. Okay, tengok dia punya hemodynamically stable. Oral route is not compromised, patient boleh makan, tak ada diarrhea, tak ada vomiting. Then what about the clinical condition, biochemical infection markers, and then the availability of the effective oral antimicrobial. So kalau ada CNS tu kena tengok oral antibiotic yang sensitif lah. Jangan bagi yang oral tapi tak sensitif pula kan. Okay, but then need to take note about the excluding of the specific indication of deep-seated infection. So patient yang SAB ataupun yang patient yang CNS ada IE. Okay, scenario patient admitted in Masuri. Okay, to cut it short, patient has been treated as the CAP lah. So was started with IV ceftriaxone. Ceftriaxone senang ya, OD. Okay, but then on day 3 of admission, patient is feeling better. So appetite, the UBC has normalized and sputum traces has come out, the culture strep pneumo. So what is our next plan? Continue IV ceftriaxone ke sebab sensitif kan? Continue je lah. Sebab kita dah treat patient betul ceftriaxone ni. Kena tukar oral sebab patient boleh oral. So boleh change to oral ceftriaxone ke? Tak ada lah oral ceftriaxone. Kita pernah dapat call, kita selalu je dapat call nak tukar oral ceftriaxone, nak tukar oral tazocine, yang ambil call pula PRP. So datang tanya kita, anak ada oral tazocine, berapa dos? Kita pun macam tazocine gitulah. And then should we change to oral augmentin or should we change to oral cefuroxime? Okay, cool. Next case scenario, patient post ELL-SCS, treated as sepsis secondary to mastitis and CAP and was started with IV augmentin and azithromycin. And then they found out that her blood culture is Staph aureus. So doktor ni pandai, dia escalate to IV chlorhexidine dah. Okay, and then upon advice, all the investigation carry out, tengok echo tak ada vegetation, repeated culture, tak ada juga. Okay, so our next plan, tukar IV ataupun change to oral. Okay, so kena ingatlah kalau ASAB oral might be inadequate. So dalam kita punya policy kita has stated kalau IV regimen, what is the oral regimen yang recommended lah. So dengan dose dan juga oral bioavailability. Okay, next is the OPED. So OPED adalah method of delivering IV outside at outpatient. So we have stated managing team kena identify suitable patient yang kita nak continue IV je. Okay, so this is just the benefit of OPED. Okay, so ni OPED service dekat klinik Viva. Kalau ada yang tak kenal lagi. Okay, so I share with one case scenario. So this patient 70-year-old Malay female. So adik ni sekolah lagi lah. Okay, so we treated with the non-healing SSI posterior instrumentation. And then bila ID review, kita start IV meropenem and due to deep-seated infection, kita plan for the 6 weeks lah. So kita nak keep ke adik ni dalam ward 6 minggu, dia pun sekolah nak SPM. Sedangkan kita just nak continue dia punya antibiotik. So what we did is we refer this patient to OPED. So patient continue untuk dapatkan dia punya antibiotik dekat OPED. So patient ni pagi pergi sekolah, balik sekolah, pergi klinik Viva, inject antibiotik. So patient happy, kita pun happy, back kosong. Okay, so in summary, so antimicrobial resistance is everybody business. So bukannya business. Resistance ni bagi dekat ID, bagi dekat infection control lah. So tak. So semua orang guna antibiotik di counselors in department apa-apa, disiplin apa-apa pun. But then we need to ensure that it is being used appropriately and safely. So, kita ada quiz kan. Okay, so that's the end of my presentation. Okay, thank you for your attention. Gambar tak ada kaitan, just untuk hiasan sahaja. Okay, so I ada sediakan satu pop quiz. Ada hadiah kan? Okay, kita traditional je. Siapa nak jawab angkat tangan. Okay, question nombor 1. Give indication of quinolones that can be prescribed without ID or intensivist ICU case or pre-authorization. Siapa nak jawab? Ada hadiah. Tinggi sikit. Rusita tak nampak.
Second line anti-tuberculosis measurement.
Okay, setuju ke? Okay, setuju. Okay, next. Okay, soalan kedua. What are the serious side effect of quinolones? Okay, boleh jawab. Okay, setuju semua? Okay, last question. What is the bioavailability of oral cloxacillin? Siapa yang download kita punya polisi je boleh tahu jawapan ni. Okay, siapa nak jawab? Okay, sebenarnya awak ni paling hebat ni. Cepat. Farmasi ke lah. Jangan memalukan farmasi. Mas Sarah tak boleh jawab. Okay, kita ada candidate. Berapa? Tadi lah agree je. Mak agree ke 90%? Cuba lagi. Apa? Tak boleh dah salah. 75. Okay, cuba lagi. Salah lagi. Alamak. Susah sangat kau soalan ni. Tak asli. 45 to 50%. So that's why patient yang Staph aureus bacteremia, we are not advised untuk change kepada oral coxa lah. Sebabnya dia punya bioavailability dia separuh je daripada yang oral. Okay, with that, pay attention.
Thank you, Cik Hana Hayati Mamat, for the very good and informative presentation. We are now open for any question or opinions from members of the floor. If there is no more question, I would like to invite.
Hello. Hai, selamat pagi. Saya bukan dari bahagian ENT. Saya ada soalan kepada Cik Hana. Okey, pasal quinolones. Saya tak tahu lah. Secara logiknya, bila kita ambil quinolones, kita sepatutnya dapat quinolone resistance kan? Kenapa dalam kes ini kita dapat anti-sedative resistance? Cik Hana. Okey, pasal quinolones. Saya tak tahu lah. Secara
Sorry, thank you, okay, because it is one of the, it is known that some of the other antibiotics, which are, for example, beta-lactams, quinolone, they are broad spectrum. So they can cause collateral damage. Actually, thank you, okay, because it is one of the, some of the other antibiotics, which are, for example, beta-lactams, they are broad spectrum. Thank you, Nalina. So basically, it causes collateral damage. But studies have shown that they also increase risk of, one of it is increased risk of MRSA. So I understand for pre-authorization, I think Oftal and ENT most common lah yang call us. We are not trying to actually not tak bagi you guna. Okay, but as you can see from Miss Hanan punya contoh, macam setengah tu, we found out that sometimes the dose is not appropriate. So our intention is one. So during bila kalau MOENT pun biasa call saya tenolida, selalu we use that time to actually sort of educate also. One is the side effects of quinolones. And the other thing is most of the time we had to correct the dose because it will not be effective. And if you use lower dose than required for the disease or infection, then that will lead to resistance actually. So macam contoh for Pseudomonas, usually it's 500 mg. So selalu kita akan tanya, what is the size of your patient? Kalau bigger size, then we recommend to increase the dose. So most of the time there will be something that tak pernah marah kan kalau call. Okay, so the other thing is that as Hanan stated, Kelantan is endemic for typhoid. So our quinolones needs to be reserved for that is the only option, oral option for oral antibiotic in typhoid. So we are quite worried. On and off, for every few years we will have outbreak. And for example, last year we had a huge outbreak, a typhoid outbreak in Penjara, and all are ciprofloxacin resistant. So then a patient would need to stay in the ward for a long time, and the other drugs is not actually good enough. So don't worry. Most of the time kita tak pernah cakap tak boleh, cuma we will help out in terms of sometimes kita tolong tracekan result and we increase the dose. It's just that the form is used to monitor the quinolone. So this is a part of quinolone pre-authorization. I think the word chosen was not really correct. I would call it as pre-authorization, not restriction in terms of restrict not to use, but more of restriction in terms of for us to make sure that it is being given in correct indication, correct dosing for the infection and also duration. So that kalau kata unit for 1 month, selalunya kita minta pharmacy release kepada patient 2 minggu. Ataupun kita tanya setengah macam contoh dia nak tengok in 2 weeks time. So kita kata bila your next CCA, dia nak jumpa 2 minggu. Boleh tak kita release 2 minggu dulu, you review, and then kalau you think that it is indicated, then we will continue another 2 weeks. So that patient tak membazir buat sampai bagi 1 month kan. Ada juga patient yang tak makan dekat rumah lah. Okay, so macam Otto pun sama. Otto pun selalu refer for OM or deep-seated infection, and sometimes by the time nak continue more than 1 month, bila kita tanya and we check, dah ada culture lain, or you did a second debridement, you get another culture, then we advise for change of antibiotics. Okay, slowly boleh bagi. Setakat ni saya tak bagi lagi. Ada jugalah, tapi yang memang tak indicated lah saya rasa. Okay.
Is there any more question from the floor? Yes, sir.
Assalamualaikum, good morning. I'm Adi from the dental department. Kalau dentistry ni, I think I don't know if it's related or not. It's SB prophylaxis for patient who's rebound basement IE and everything lah. So it's common for us to give antibiotic prophylaxis. Common is 2 gram of C or 2 gram cephaloxime lah. Previously it was clindamycin. So kalau it's a routine thing that we give, can it cause the resistance juga? Because this is an outpatient setting, we do like extraction and foliation and the treatment. Thank you.
Usually for as a prophylaxis, you are giving short course. For example, your penicillin, your second generation cephalosporin, we are not that worried if you are giving short course for prophylaxis. But for other antibiotics, for example, so in your setting, yes, it can somehow leads to resistance. If it is given, the problem is that sometimes kalau prophylaxis yang disambung, macam for surgical prophylaxis, tapi some physicians or surgeons dia suka sambung, kan? Macam sepatutnya kalau dalam keadaan yang tengok step dose. I understand if the operation is long, then you continue because of the nature, the frequency of antibiotics. Tapi the practice of continuing beyond what is indicated in the guideline, because they are all guidelines, and in our national antibiotic guidelines pun kita ada stated kan, continue for 3 days. Biasa tengok kan, medical officers pun biasa tengok dalam ward. Yang ni kita kenapa antibiotics. So if you continue beyond what is the recommended dose, tapi kalau bagi step dose saja, it should be the risk is very low. But for some antibiotics, for example, carbapenem, the 3rd generation cephalosporin, even carbapenem with just 1 or 2 single dose, you already had a risk of acquiring multi-drug resistance. But for short dose, that's why for surgical prophylaxis, please do not continue beyond what is recommended. I think everybody knows that the recommendation is pre or post, or you can extend, you give another dose if your operation is longer. So if beyond that, you extend, I'm not sure to treat yourself, or you think that this is not adequate. So if patient acquire MDRO, then dalam MDRO tu dia ada slide signature initial nama ni bagi dosis sikit.
Okay, do we have any more questions from the floor? Okay. So now I would like to invite everybody to enjoy multimedia presentation prepared by AMS team.